Hello and welcome to Rehab Reels, conversations on physical medicine and rehabilitation, hosted by Dr. Gwen Soa. My name is Andy Ziegler with the University of Pittsburgh and UPMC. I'd like to welcome everyone joining us today for this special presentation on new directions in PM&R education. You may submit questions for our presenters using the Q&A feature on your screen. We will do our best to get to as many questions as possible during the allotted time. Our series host, Dr. Gwendolyn Soa, is the endowed professor and chair of the Department of Physical Medicine and Rehabilitation at the University of Pittsburgh School of Medicine and is the director of the UPMC Rehabilitation Institute. She holds joint appointments in the departments of orthopedic surgery and bioengineering and has served as a clinician scientist in the Department of Physical Medicine and Rehabilitation for over 15 years. Our invited featured guest is Dr. Wendy Helkowski. Dr. Helkowski is an associate professor at the University of Pittsburgh School of Medicine and is the residency director and vice chair for medical education at the UPMC Department of Physical Medicine and Rehabilitation. She has served on educational committees and conducted oral examinations for the American Board of Physical Medicine and Rehabilitation and the American Association of Neuromuscular and Electrodiagnostic Medicine, and is the current chair of the ACGME Review Committee for PM&R. Her clinical practice focuses on electromyography and outpatient musculoskeletal medicine and disability. She was also peer selected as one of Pittsburgh's best doctors as part of the Best Doctors in America list. Dr. Soa and Dr. Helkowski, thank you so much for being with us today to provide some insights on the current landscape of PM&R education. Dr. Soa, the floor is yours.
Thank you very much, and thanks everyone for joining us again this evening. Welcome to all of our rehab friends, and hopefully this is welcome back for some of you who may have joined us last month for Dr. Amy Haltrow's presentation on health disparities. So we're excited to be back with you and really continue to look forward to connecting with you virtually and sharing updates and innovations from our department as well as the Rehab Institute. Today's topic is equally timely to last month with a focus on education of our future generation of physicians and physician leaders. Certainly with our experience over the last 6 months, we know how important a strong workforce is going to be ensuring that we can continue to meet the demands of ongoing healthcare challenges. And as well as we continue to work hard to ensure a very diverse workforce of physicians to care most effectively and efficiently for our entire community. More specifically to rehab, a recent workforce study has shown that the importance of physiatrists or physicians trained in physical medicine and rehabilitation, which are those physicians who focus on function and quality of life, as well as care for people with all types of disabilities who lead long, productive lives. The need for these physicians will continue to increase with our aging population, particularly in our local region. So Pitt and UPMC's a real force in contributing to this important goal, as you'll hear about tonight. We're currently ranked 5th in the country for PM&R residency programs nationally. And Dr. Helkowski, as you heard, has been a leader not only locally, but also nationally, helping to really set the standard of how we assess the quality of the training of our future physician workforce. So her topic today highlights these innovations in medical education, which make our institution great and really have a big impact on the field in general. And I know you'll be impressed by not only where we've been, but where we're going. So Dr. Helkowski, please.
Thank you, Dr. Soa, for giving me this opportunity to review some of the new directions in PM&R education occurring during these turbulent times. It's a topic that I'm excited to discuss with all of you today, so let's get started. First, I have no conflicts to disclose. So over the past 20 years, medical education, and in particular graduate medical education, has been a focal point in my career. And I must say that it's never been as challenging or as rewarding as it is now. As the program director of the UPMC PM&R residency, I have never experienced the need for such rapid changes in the program until this past March. It started with the COVID-19 pandemic that forced us to very quickly adapt our patient care and teaching models to keep our patients, residents, fellows, and faculty safe and well. And then, in the midst of the pandemic, in May, George Floyd was killed in police custody, triggering nationwide protests over racial injustice with a demand for accountability and change that continues today. These monumental events and their impact on our PM&R educational programs, as well as their impact on physician wellness, will be the focus of my talk today. So let's start by walking through a timeline of the arrival of COVID-19 in the US and its subsequent impact on medical care. So it was just 9 months ago, in January of 2020, that the first US case was recorded and the World Health Organization declared a public health emergency. Not long afterward, in February, US declared a public health emergency, but it was really in March that we started to see a significant impact on medical care. The World Health Organization declared COVID-19 a pandemic. Centers for Medicare and Medicaid Services expanded the use of telehealth or video visits with patients to protect Medicare patients. And social or physical distancing, a phrase which many of us, including me, had not even heard of previously, became commonplace. And state and local governments issued stay-at-home orders, and elective procedures and office visits were canceled or reduced. An interesting study by Dr. Escalon and others was recently published in the PM&R journal. And the study included a survey of 172 PM&R residents and 178 PM&R faculty from across the country to assess the immediate impact of the coronavirus pandemic and adaptations in education and practice. And I'm happy to mention that one of our own PM&R residents from UPMC, Dr. Jim Eubanks, was an author on this paper. The table on the slide shows the national impact of COVID on telemedicine and PM&R attending practice. So as you can see, prior to COVID-19, about 16% of attendings had completed telemedicine visits, whereas post-COVID-19, it was up to about 86% of attendings completing telehealth visits. This was a tremendous and rapid increase in the use of telehealth. And the residents who were surveyed reported a change in their rotations from mostly inpatient care to outpatient care during the survey period. And 13.5% of the residents were redeployed to non-PM&R services such as medicine floors, ICUs, and emergency rooms because of the need for physicians in those areas. This is a graph that shows data from our own UPMC PM&R department comparing face-to-face or in-person visits with telemedicine video outpatient visits pre and post-COVID. So in the first bar, before March of 2020, only about 1% of our patients, the little tiny pink line at the very top, were being conducted through telemedicine. The vast majority were face-to-face visits. And in contrast, in March and April, our PM&R physicians and patients had to quickly adapt and learn how to conduct visits by video and by phone. And as you can see, the outpatient visits in March and April were primarily telemedicine, about 75%, with only 25% at that time occurring face-to-face. And then in the last bar on the right, from May until now, you can see that the face-to-face visits have significantly increased back to about 80%, but that still means that 20% of our visits remain telemedicine visits, especially follow-up visits, which seem to work well in the video format. And this is going to be likely to continue indefinitely now that we're comfortable with this format. And it allows us to continue to care for our vulnerable patients who may not be able to safely come into the offices even now. Here's a summary of the resident experience at UPMC in PM&R during the beginning stages of the pandemic. The UPMC PM&R residents were placed in a platooning model for about 6 weeks. And what that means is it was a schedule where half of the residents were in the hospital taking care of patients, and the other half were on reserve, working remotely from home, doing telemedicine, remote assistance for inpatient care, as well as other research, administrative, and educational activities, unless they needed to be pulled in for inpatient care in case one of the inpatient residents was quarantined due to a COVID exposure. Because the COVID-19 cases remained manageable by the emergency room, medicine floors, and ICU teams, none of our PM&R residents were redeployed to any of those areas of the hospital. Several of our residents did miss consecutive educational experiences, however, in things like musculoskeletal medicine and electrodiagnosis that required adjustment to their schedules for this year to make sure that they were able to make up some of the experiences that they missed in March and April. Unfortunately, none of our senior residents who graduated this past June needed to delay their graduation. They were all able to achieve their competency and procedure experiences in order to graduate from the program on time. At the onset of the pandemic, national organizations such as the Accreditation Council for Graduate Medical Education, or the ACGME, allowed for resident rotation changes in order to care for patients and also to protect our residents and fellows. They also allowed for situations where faculty could supervise residents using telecommunication or video technology to supervise. The American Board of Physical Medicine and Rehabilitation that certifies individual physicians in PM&R allowed additional time off from training if it was due to illness or quarantine from COVID-19, while still requiring that the programs must make sure that the residents are competent to be independent in practice before they finish the program. And national PM&R societies were also active in helping programs by organizing virtual lectures that were provided free to programs to supplement their own lecture series. And the article by Dr. Escalon and colleagues also looked at the adaptations in PM&R residency programs across the country. So prior to COVID-19, only about 20% of the residents attended virtual didactics or educational sessions in place of the usual in-person didactics. Whereas post-COVID-19, almost 93% were attending virtual didactics. About half of the residents were in programs that collaborated with other institutions, and about 80% attended virtual didactics from other organizations. So what this shows is that there was significant collaboration among residency programs and resources that were provided from national organizations to facilitate ongoing education despite the pandemic. And I'm excited to share some of the innovations in education that occurred within our own UPMC PM&R program. For inpatient care, our department was able to utilize video platforms to allow residents and faculty to attend bedside rounds where they would go to see patients, and whoever was in the hospital would bring around a portable computer that was had installed video software and camera that allowed some of the team or the residents or the faculty who were remote to still be able to participate in those bedside rounds. And this was also useful for team discussions. So typically we might have physical therapists, occupational therapists, nurses, speech therapists, sometimes patients, families, the physicians that will all gather together and talk about the care of the patients. But during this time with COVID, they were not all able to safely gather together. And so video was very useful to help with team-based care as well. For outpatient care, one of our fellows was able to perform procedures with telesupervision from a supervising attending physician who was not physically in the room, but was able to supervise and direct the procedure through video communication. Outpatients were able to be seen through video telemedicine with both the resident and the supervising attending appearing on the screen with the patient, and they were able to conduct the visit with the patient in their home and potentially the resident or faculty in their homes. And then the resident and attending could stay on after the patient visit and review teaching points at that time. And speaking of teaching, the UPMC PM&R faculty quickly became proficient in providing teaching presentations through video conferencing, presenting slides or articles, and they were able to do it in a way that allowed for some interaction with the residents participating through the chat functions on the various platforms or participating vocally by unmuting themselves and carrying on a dialogue in an organized way. A couple of the attendings came up with some innovative ways to teach musculoskeletal ultrasound during the times when we really were not gathering at all. So one of our attendings has a musculoskeletal ultrasound machine at home and was able to set up a camera to do a video recording that allowed him to project a live video session of himself, scanning his own limbs and describing the methods he was using and the structures that he was seeing for the residents who were watching remotely. And other attendings reviewed scanned ultrasound images that residents had collected on their own, time and then labeled for the attendings, sent it to them, and the attendings were able to provide feedback and teaching in that way as well. So medical student education was also significantly impacted by COVID. And this is a subject near and dear to my heart for several reasons. One is that the first-year medical student pictured here in this slide is my own son. And he has described for me the virtual classes and simulated patients that have replaced inpatient or in-person classes and patient interactions, which is a very different experience from when I was in medical school a long time ago, but also a very different experience from just 1 year ago. Students are required periodically through their 4 years to take standardized board exams in learning centers, and many of those were canceled or rescheduled due to COVID. And as a result, some of the results of these exams won't be ready in time for the interview season this year. Also, March through November is typically a very busy time for electives, elective rotations in PM&R, where medical students have the opportunity to learn more about the specialty and to obtain letters of recommendations from faculty to support their application to their residency programs. However, COVID-19 caused in-person away electives to be mostly eliminated. A few programs across the country were innovative and created virtual rotations that allowed students to participate remotely through video teaching, conferences, patient experiences, simulated cases, things like that. But for many students, the opportunities were very limited. And my heart also goes out to the fourth-year medical students who are currently preparing to enter a virtual interview season this year, where they will need to learn excuse me, about potential residency programs through videos and virtual interviews instead of visiting the programs and the new cities in person. So for the fourth-year students who are listening to this talk today, I wish you good luck with your interviews, and I look forward to reviewing your applications next week. So I'm going to change directions at this point and move to the impact of COVID-19 and health equity. Resident and student experiences and education were not the only impacts of COVID-19 on our programs. The pandemic highlighted the systemic health and social inequities that increased the risk of death from COVID-19 in racial and ethnic minority groups. The CDC describes several potential contributing factors for worse outcomes in these groups, including discrimination and the associated stress of dealing with racism that produces an increased risk for illness, a lack of healthcare access, and inequity in education that limits job options, often placing racial and ethnic minority groups in jobs that have a higher risk for exposure to COVID-19. And one resource that can potentially help address these disparities is a diverse physician workforce. A diverse workforce can help bring into focus and prioritize the mitigation of health disparities among racial and ethnic minority groups. However, all physicians in training, not just the minority physicians, must learn about health equity and racial and ethnic disparities, how to mitigate them, and how they can be part of the process. In 2017, the ACGME added requirements for all residency programs to make sure that their residents learn about population health, healthcare disparities, and social determinants of health. And residents are all expected to be responsive and respectful to a broad range of diverse populations. So how can programs accomplish these important tasks? There are plenty of online lectures and modules from national organizations, such as the Institute for Healthcare Improvement, which offers high-quality educational materials for physicians. In addition, I feel that residents really should be involved in quality improvement processes designed to actually address healthcare disparities. And I have an example here on this slide that is an ongoing quality improvement project in our program, our PM&R program, that was inspired by our rehab patients who require a wheelchair for functional mobility. And in this project, our residents chose to evaluate the accessibility of many of our outpatient clinics that are used by the patients that we see in PM&R. So this evaluation included things like enough space in the waiting room and in the patient rooms to allow for wheelchair turning and navigation, accessible heights of bathroom facilities, including coat hooks and accessible examination tables. And in a preliminary report on this QI project, the group found that our outpatient clinics were generally structured to be accessible for our patients, but in some areas, improvement is needed. For example, in some of the bathrooms, the coat hooks were installed too high to be accessible from a wheelchair. In another bathroom, a large garbage can in the room caused insufficient space for wheelchair turning. And in the waiting room, chair spacing had been adjusted to be compliant with the new social distancing rules, but now didn't allow enough space for a person in a wheelchair to easily approach the check-in window. And based on these preliminary findings, actions already being taken to address these issues for our patients. And I feel that resident involvement in these projects where they can see the improvement take place, as well as involvement in actual patient case discussions, resonate more from a learner perspective. And as you can see from this picture, this cartoon picture on the slide, one size fits all doesn't work very well. So having multiple ways to teach and reinforce these important concepts can lead to better results. Another recent emphasis from the ACGME on a national level and also from individual medical schools and hospitals is a demand for increasing diversity among our residency program residents, fellows, faculty, as well as staff through intentional recruitment efforts. In an article by one of our UPMC graduate medical education leaders, and she is also a University of Pittsburgh School of Medicine leader and dean, Dr. Alda Gonzala and colleagues described a framework with 5 key steps for recruiting a diverse and inclusive workforce. And the framework starts with that circle at the top with setting diversity as a priority and letting applicants know about it. So put it in your mission statement, put it on your website, let applicants know that it's a priority is one of the first steps that you can take if you're looking at an inclusive recruitment process. And I'm going to go through some of these other ones in the next few slides. So let's talk a little bit more detail on the holistic review of applicants and an inclusive interview process. Holistic recruitment or holistic review of applications is a flexible, highly individualized process that involves balanced consideration of experiences, attributes, and academic accomplishments, and really avoids relying solely on board scores, rotation grades, things like that for interview selection and ranking. And this can be challenging for programs. Some programs get hundreds, or even some of the medicine programs get thousands of applications, and it can be challenging to do this holistic review instead of just using a score to cut off and, then it's an easy number that you have to manage. It's a challenge to do, but it's worth taking the time to allow for more diversity and inclusion in the programs. And the next step after looking at your recruitment process is to look at the recruitment committee and mitigate potential bias in the recruitment committee. So implicit bias training for the recruitment committee can be helpful in that, and I'm going to talk about that a little bit more on the next slide. Okay. So Dr. Gonzala and her colleagues describe actions that programs may take to create an inclusive culture that fosters success in residency, as well as retention of diverse residents and fellows as faculty members in the program. Education for residents, fellows, and faculty in bystander training, where they learn techniques to intervene when they witness actions or statements in the work environment that show bias or overt racism, can be helpful. And because there may not be enough diversity in the faculty or residency to have mentors that share racial and ethnic backgrounds, training faculty and residents to mentor across differences can be effective. Having them look at things that they have in common with some of the individuals that they are mentoring, even if they don't share racial or ethnic backgrounds, can be helpful. And in addition, training in unconscious or implicit bias and mitigation techniques is important not only for that recruitment committee, but for all of the program faculty and residents. And if anyone listening today has never taken an implicit bias test or implicit association test, I would encourage you to do so. Just search implicit association test online and take a few of them and see what you find out. In a collaboration between UPMC and the University of Pittsburgh School of Medicine, a series of anti-racist lectures has been developed with the plan to implement these widely to students, residents, fellows, and faculty. And as you can see, we have topics such as racism in medicine, social determinants of health, bystander training, microaggressions. Potentially this collaboration between different institutions could lead to greater change. So, given all that I've talked about so far, it's more important than ever to focus on physician and medical student well-being in this current environment where we have stresses associated with systemic racism. There's stress associated with the potential for you being medically susceptible to not only contracting COVID-19, but having a complicated course from it. Stress about spreading COVID-19 to your own family, to your patients, to your colleagues, are things that I think that lead to an increased need to focus on well-being. Recent surveys have revealed the prevalence of burnout among physiatrists. And burnout can be characterized by a feeling of exhaustion and an indifferent attitude about work and limited ability to accomplish things at work. And this bar graph on here is a Medscape National Survey of Physicians, and it shows that 43% of physiatrists reported symptoms of burnout. This puts PM&R physicians in the top half of the specialties surveyed, tied with emergency medicine and just below internal medicine. And Dr. Sliwa and others from the American Board of PM&R surveyed 1,536 board-certified physiatrists and found that over 50% filled the criteria for burnout. So as you can see, it's a prevalent problem. The problem of burnout is exacerbated by racial discrimination in minority students based on this study that looked at race and ethnicity and impact on medical school experience. 11% of minority students cited that racial discrimination, racial prejudice, feelings of isolation, and different cultural expectations caused an adverse medical school experience. The students reporting these experiences were more likely to experience burnout and depression compared to students without such experiences. Over the past several years, in an effort to combat burnout, depression, and worst of all, physician suicide, the ACGME has emphasized physician well-being in their requirements for all programs. First, programs must make efforts to enhance the meaning of being a physician. And what does that mean? So as an example, survey of residents have shown that more time with patients is valuable to them and it enhances the meaning. Less time in front of the computer, putting in orders, writing notes is valuable to them. So trying to enhance the things that are valuable, trying to streamline the things such as the documentation burden is also valuable and something that programs need to think about. Attention to scheduling, work intensity, and work compression is also something that the program and the institution can do to help with resident and fellow well-being. And residents and fellows must be able to attend to their own wellness by being able to go to medical and dental appointments, even those during work hours. Educational programs have to also do educational sessions on recognizing these symptoms of burnout, depression, and substance abuse in oneself and in others. And residents and fellows have to have access to self-screening tools and 24/7 access to treatment for mental health. National resources for well-being are also available to help programs, residents, and fellows. And one of our residency graduates from last year, Dr. Allison Schrader, created and chaired a national well-being subcommittee of the Resident and Fellow Council of the Association of Academic Physiatry. And this subcommittee advocates for physician wellness and provides resources through social media and website platforms that are available to residents, fellows, and programs. And the ACGME also has plenty of online resources for resident and fellow well-being to help programs. An example of hospital and institution level resources from UPMC include an online well toolkit that our well subcommittee of our GMEC spent over a year developing in collaboration with others around the country to provide educational materials, self-screening tools, and a guide to resources for mental health and well-being for our programs, for our residents, for our fellows and faculty. And one example of these resources is shown on this slide is called Curbside, which stands for Confidential Referrals for Behavioral Health. And this service provides private and convenient psychiatric and behavioral health care for physicians and their family members. Within our own PM&R program, we have well-being resources that are funded by the department, but directed by the residents. We felt that the resident leaders in the program would be the best ones to be able to plan relevant, impactful activities to enhance resident and fellow well-being. The last thing we wanted to do was to implement some measures for well-being that added any additional burden to the residents. So we let the residents help guide us in this. There's a resident wellness committee that has 2 enthusiastic resident leaders and other residents who participate in the committee, with faculty participation and advocacy, and some of the innovative ideas that the residents have turned into meaningful wellness activities include Props for Docs, which is a monthly anonymous survey that goes out that allows faculty and residents to give positive feedback, to say something nice about something good that a fellow physician did over the last month. There are exercise activities such as biking that they do together as groups and charity 5K races. One of our residents is a yoga instructor, and you can see pictured on the left there that a yoga session that occurred in one of our didactic days led by one of our own residents. On the right is a Meet the Babies event that was pre-COVID. Post-COVID, we've moved to more virtual activities such as virtual barbecues, where the residents will be in their own home getting set up for some delicious barbecue meals and showing videos of them and pictures of them, or participating on a Zoom format to make it be a group activity as well. And then the program also provides educational sessions that are related to well-being for the residents as well. So in order for educators to train outstanding physiatrists who not only possess the knowledge and skills associated with the field of physiatry, but who are culturally sensitive, inclusive, aware of their own potential biases, active in addressing healthcare disparities, and aware of the need to balance their own well-being with their patients' needs, and, by the way, all of this during a pandemic, which is exacerbating all of these problems, we must innovate. And luckily, we're not alone. Our national societies, institutional GME resources, and shared educational materials from other programs can help us navigate these complexities. So I'd like to thank everyone for your attention, and I would be happy to take your questions.
Thanks so much, Wendy, for sharing all that. And it's really awesome to see this all kind of put together and see where we've been and where we've come to. Our trainees are certainly in good hands, and I know that you've had some great partners in our chief residents and other leaders
Definitely
in the department. So maybe while people are thinking of questions, which feel free to post in the Q&A section, maybe I'll start with a question. And we flip things on very quickly in terms of how the changes we had to make. And you talked about some of the changes we made and made it sound pretty easy and seamless. And I wonder if you could comment on some of the barriers that you found to making these really rapid changes into a virtual education and clinical experience for our trainees, for our residents during the pandemic.
Yeah, sure. I would say it definitely was not easy, and there were a lot of evenings and weekends that I was spending time trying to figure out how to manage some of these things with with the scheduling and how to make it work. And Not only that, but equipment and software issues where it came up. So faculty and residents needed to download software onto their personal phones, computers, tablets, just to be even able to think about conducting telemedicine visits from their homes. The department had to pretty quickly purchase some of these equipment to make that accessible to people. The staff needed to be trained to teach patients how to use this equipment. And so it was, a little bit of a bumpy start, I would say. And my first telemedicine visit with the patient didn't go so well. The patient couldn't figure it out. I wound up calling her on the phone. So that made me make sure we had some backups and things like that. So, there were some challenges there. But the other thing that was a little bit challenging was the residents, coordinators, and faculty needing to pretty quickly learn how to manage Zoom, Teams, YouTube, all the different platforms that we have for our video conferences. And I'm sure we've all participated in a lot of these conferences at this point where people had trouble sharing their slides or finding their presentation, or their video was cutting out, or we couldn't hear them talking. And so there definitely were some bumps to work through that we had to do it pretty quickly, but I think it was all worth it.
Yeah, absolutely. And I think what's been so impressive is the willingness to try something new. People, despite all of these things being unknowns, and certainly the trainees are a little more tech savvy than the attendings, but there was an incredible willingness to try and to be flexible and to do something different.
Absolutely. And you mentioned the residents. The residents were wonderful. They had so many great ideas, from coming up with how to do that platooning schedule that we were talking about, to one of our chief residents, who's our academic chief resident, in arranging didactics, and she had the schedule all made up, for April, May, that was going to be in person, and then, like turning a light switch on or off. She had to come up with a way to do this all virtually. So the residents were really amazing helpers in this process.
Absolutely. Absolutely. And of course, there's always a silver lining, right? And actually, one of the things I wanted to bring up, Dr. Quarterbein on the Q&A had brought this up about what you think happened as we turn this all on that will continue when the pandemic is over or evolves, or however we deem this is gonna move forward. So what do you think the changes that we were able to get up and running quickly, what do you think will endure?
Well, I definitely think that telehealth is going to endure. I know from my own standpoint, we in our department had been incentivized and been given instructions on how to do telehealth, but it was kind of optional. And then so many of us had never even tried it. And then March came along, and we just really had to do it quickly. And now that we all know how to do it and we're comfortable with it, we're certainly more likely to continue with that. But the other thing that I found to be particularly helpful, not only with the residency program, but with some of my other academic work that I'm doing, is some of these virtual conferences. And we in our residency program have multiple hospital sites, and the virtual conferences is saving some of our residents some time traveling back and forth between our different hospital sites, and I think is allowing more of our faculty members to participate in residency conferences and discussions, which has really been a plus. In addition to that, we've conducted some of our evaluation, or all of our evaluation meetings with residents virtually, and now they don't have to leave necessarily their clinical site to travel somewhere else to meet with me to go over those evaluations. We can do it virtually, and that gives us all maybe an extra hour in our day to focus on our patients or our own well-being, and do other things with that time.
Yeah, absolutely. I mean, we've certainly seen attendance at many of our events, whether they're local or national, increase because they're virtual, and people have an easier way of getting on, and those geographic barriers no longer exist. You mentioned the the use of the virtual platform for our interview season. And there's a question in the chat from Alan Swick, a medical student, who asked about ways for applicants to learn more about the program since we are doing all of these things virtually, and what opportunities for touring facilities, meeting some of the residents, what are some of the things that we have available?
That's a great question. We certainly have a website that we've had, and that's nothing new, although we've updated it. We also have been much more active in social media to try to inform our applicants about some of the things that are important to our residents. So, for example, on our Instagram site, they've been posting a series of get to meet our PM&R residents, and they've gone through our PGY4s and our PGY3s. I think they're on the PGY2s now. And those residents are submitting pictures of themselves and some of the activities that they like to do to allow for applicants to kind of get a feel for that. But they're also posting some of the academic things that we're doing, some of the awards that our residents are getting, so they can get an idea of some of the great things that our residents are doing. Some of the research and the presentations are also on there as well. And we have done 3 Zoom sessions so far that we've conducted. One was a session that was arranged by the PM&R Scholars Group, and we, in partnership with 3 other programs, did a session a couple months ago. And since then, I think just about every program in the country has done one of these as part of this PM&R Scholars group. And then we did one of our own that was a little bit more formal, and then the residents did one that was a little more informal, where they broke out into different rooms, and they each had a kind of a focus point to start a conversation. Like one room was on biking, outdoor biking, and another room was on research. And so it kind of started the discussion in a little bit more casual, informal way. We don't have another one of those scheduled, but if and when we do, we will definitely post that on our social media sites for students to find out about and participate in.
So all these ways to connect both professionally and personally.
Yeah.
Virtually. Yeah, it's great. So there's a question from our colleagues across the way in Geisinger from Liang Chen, who asks, with musculoskeletal visits, and you and I both had some practice with this, how do you navigate a musculoskeletal visit virtually? So in a field like ours that is so hands-on, how do you do a musculoskeletal visit? And the second part to that question is how to determine when we should do a virtual visit versus an in-person visit. Thoughts on that?
Yeah, I think that's been challenging, particularly for new patients. And in some that are relatively straightforward, and you can have them do some very basic physical exam things like range of motion and palpation and some general strength things and gait. You can assess those on video. But for some of the more complex patients, and I see patients in the electrodiagnostic lab that to me, seem like somebody that I would perhaps like to bring in for electrodiagnostic testing. I feel like those patients, I really don't get a good feel for what's going on with them unless they would come into the office to see me. Whereas in my patients that were follow-ups, I had already seen them in my clinic. I had done a physical exam, and I was adjusting a medication, or I was kind of seeing how they responded to an injection or physical therapy. Those were much more amenable, or easily amenable, I felt, to these video visits.
Yeah, absolutely. I agree with that. And sometimes it's hard to know a priori, but what I've also experimented with myself a little bit is virtual physical exams. So if a patient is in a safe environment and you can get them to do a few things, it's kind of interesting how much you really can assess in terms of strength, range of motion, function virtually if the person's in a safe environment. And
yeah,
certainly within our being a strong research program here, we've and having such a large patient population, we started to study this. We have a very ambitious medical student who's done some work looking into the databases and seeing what are we missing. I think that's going to be an important question as we come out of this. What patients are well suited to a virtual visit, and which patients did we do a virtual visit that maybe we really should have seen in person, in case
Yeah.
something missed. But at the same token, what we can also see is that those virtual visits, because they're so much more accessible to our patients with various kinds of disabilities, might actually improve their access.
Yeah, absolutely. I mean, there are some of our patients who, because of medical fragility, are very reluctant to still come into the clinic setting, and it's certainly better to be able to talk with them and see them through this video platform instead of them not being seen at all.
Right, absolutely. So I wonder if we could switch gears a little bit and talk about some of the diversity-related initiatives that you talked about. So, certainly our underrepresented minority students, residents, fellows may be more likely to have experienced discrimination, microaggressions, maybe even burnout related symptoms. And you mentioned some of the training and mentorship to try to help prevent that. But I wonder what other supports or resources that you think have been or can be put in place to prevent some of those things.
Yeah, I think that's an important point. I do believe that additional resources really can be helpful to our minority students, residents, fellows, and even our own faculty, designed to provide support for those who experience racial discrimination and feelings of isolation. Within UPMC and also the School of Medicine, there's a lot of collaboration in this regard. So there are shared resources for education, for mentorship, for support. And in particular for our residents and fellows, there's an organization called the UPMC Coalition of Residents and Fellows of Color, or CROC is the name for it. And they have mentorship, they have sessions such as one called Cyber SIP for Survival and Wellness. And that event includes open discussion regarding physician wellness specifically as a minority, and talking about some of the minority health disparities and engagement and getting involved with that I think is really appreciated among the faculty and the residents who participate in that group.
Yeah, it's a lovely event. I participated before in that myself, and glad to hear that it's still being done virtually.
Yeah.
Cyber sipping.
That's right.
Great. Well, we'll go to Andy to see if there are any other questions on the post, but while he's looking there, I have to bring up the well-being topics that you discussed. So I think, speaking personally, I know that our faculty often learn from the residents, right, in terms of how to better manage wellness and balance or harmony.
Yes.
Work and personal
absolutely
life. Wonder if you've heard anything from, so we've been paying more attention to this and doing more dedicated activities for the last several years. Wonder if you've heard anything from our alumni about how have they been able to carry that over? How's that going after they get out of their training program?
That is a wonderful question that I don't have an answer for, but I would be curious to find out about that as well, because I know that during residency we had people who were so active in this, and even at a national level, and continue to be active at a national level in this. And I do wonder also when they're out in practice and they're having to manage things without I don't know, I guess without someone overseeing to make sure that they're well, they have to do it on their own a little bit more, whether they're able to still maintain that wellness and balance. I don't know.
Yeah, maybe a good research project for one of our upcoming residents, medical students interested in the program. It'd be interesting to look at.
That would be.
Yes, there is a question. This is for the benefit of medical students. You had mentioned earlier about a holistic review when doing recruitment.
Yep.
And you had mentioned about looking for unique experiences or attributes that may stand out above perhaps a lower test score in a certain area. Could you give some examples of some things that you may look for or have found regarding those types of unique experiences or attributes?
Sure. As part of our application review, we take a close look at the personal statement provided by our applicants. And in that personal statement, it's often a very rich place to find people who have unique backgrounds, unique experiences, things that show that they would add a different perspective if they matched into our program. We found that I personally find that with each group of residents that come through, I learn more from them, I think maybe than they learn from me in, them providing some feedback and experiences, and, they leave the program a better place than when they started it. And so looking in their personal statement for things that suggest that this person's really gonna bring a rich culture to our program. But we also look at things like leadership activities that they've done, volunteer activities that they've done, research that they've conducted as a medical student or an undergraduate student before, any honors or awards that they've received, not necessarily just for academics, but for other things as well. A number of people might come through and they've gotten awards in other areas, like in the Girl Scouts or the Boy Scouts or things like that, where we can see that they have achieved in other areas, even outside of medicine, are just a few of the examples of what we're looking for.
Always awe-inspiring to see what hidden talents
Yeah,
our residents and candidates have. Yeah, absolutely. So I'll just say we're speaking personally and locally, we're very fortunate to have Dr. Helkowski in this role, and the amazing impact she's had not only on our trainees, but trainees all across the country, with the influence that she's had nationally in some of these initiatives. So thank you for joining us tonight, Wendy.
Yeah, it's my pleasure. Thank you for listening.
Absolutely.